So first of all, good morning. My name is Jessica Lim. I'm a nurse practitioner here in the cath lab. And I want to thank you guys for coming here. Last year, we missed it because of COVID. And I just want to thank all you guys for, getting out of our normal situations. A lot of us were deployed into the front line. So I really just want to take the moment now to thank you guys. And also want to thank Dr. Kinney, Dr. Sharma, Heidi, and Beth for asking me to speak today. So I'm going to be talking about In-Stent Restenosis, current update in management. Unfortunately, I have no disclosures. And I'm going to start off with a case study. So it's a 56-year-old male with past medical history of hypertension, hyperlipidemia, insulin-dependent diabetes, ex-smoker who presents with complaints of chest pain and dyspnea on exertion. His exercise tolerance was 2 blocks, so that's CCS class 2. He had a submaximal stress echo, and because of his symptoms, he was brought for cath. So here's a picture of his LAD. You could see he has an 80 to 90% stenosis in the proximal section. Mid-LAD has 90 to 95% stenosis. Here's the fixing with the rotablator, balloon and stent. And he actually, so here's the post-procedure, great picture. And he actually came back about 14 months later, complaints of chest pain and shortness of breath again, did another stress echo, had some ST depressions, and this was him 1 year later. So what is in-stent stenosis exactly? So the definition that I found was a luminal narrowing with greater than 50% diameter stenosis of a stented coronary artery segment or within 5 millimeters of a stent edge. So you could see the cross-section here of the artery post-stent deployment, and to the right you can see the in-stent restenosis cross-section. And I found it interesting that they called in-stent restenosis the enemy of interventional cardiology. As nurses and techs, you know how great it feels when your patient feels chest pain-free post-procedure. And over time, we see the same patients and how frustrating it could be for the patient and for us when they block up again. Luckily, the incidence of in-stent restenosis has gone down. With the bare metal stents, they're rarely used now. If in-stent restenosis occurs, it's usually within 6 months. It was a 17 to 41% occurrence of in-stent restenosis with the bare metal stents. And as we spoke, the drug-eluting stents that we use more now, even the first generation versus the second generation, you can see the decrease in in-stent restenosis. The first generation is 13 to 16% at 5 years, and the second generation DES has a 5 to 6% incidence of in-stent restenosis. And as Dr. Sharma, Dr. Sweeney spoke, these drug-eluting stents are better in terms of the platform and the polymer. They're much thinner compared to the thick stents that were previously used. Also, the drugs that is used is specifically designed for intracoronary use. And here's a representative types of in-stent restenosis. So basically what happens is there's this pathogenesis where there is non-specific inflammatory response to vessel wall injury due to persistent insult by a foreign element such as the metal struts of the stent. And also with neoatherosclerosis, there's an accumulation of macrophages in the neointima. So that's what really causes the narrowing of the arteries. Some possible mechanisms of restenosis after DES, there could be some drug resistance. After the procedure, our patients are on aspirin and either Effient, Plavix, Brilinta. And if they come in for ISR again, sometimes we find out that they weren't responding to the Plavix. So what we'll usually do is we can draw a PRU to see if the platelets reacted to the Plavix, and if not, switch it to another agent. Also, some mechanical factors such as stent underexpansion, stent fracture. So that's why it's very important for the interventionalist to choose the correct stent size, the balloon, the stent type. And here are some types of in-stent restenosis that were defined by Dr. Moran, who works at Mount Sinai. There's the pattern 1, which is focal, pattern 2, 3, and 4, which is diffuse, and then pattern 4, on the very bottom, you see it's a total occlusion. So in JAC 2020, they actually did an article showing the trends and outcomes of restenosis after coronary stent implantation in the United States. And what this was, it was a retrospective study that analyzed how many, the factors that are very common in patients that have ISR. So you can see here basically what we know already, this cardiovascular risk factors. A lot of people that had ISR had hypertension, hyperlipidemia, diabetes, they were smokers. Also, they had a history of prior MI, heart failure, or CABG. And the clinical presentation, they also analyzed this on patients that had ISR. Some patients have presented either stable angina, unstable angina. They had non-STEMI or STEMI, or some people didn't even have any symptoms at all. But here it shows that unstable angina occurred in about half. And also the ISR time frame, they analyzed that. My patients always worry about when it can occur, and especially talking about the advancements of drug-eluting stents, it's very hard to tell. But this shows that about half occurs after 2 years. So some nursing considerations to think about are the recurrence of angina symptoms. A question that I like to ask my patients, I always say, is the pain similar to your last PCI? Doesn't necessarily mean that we're gonna bring them straight for a cath, but you do a stress test, do a coronary CTA, and based on those results, see if we need to bring them back. Also, compliance with DAPT. As we were talking, they are placed on aspirin and P2Y12 inhibitors. Some people actually don't understand how important it is to be on both for at least a year, but also depending on the type of stent. There are some urgent surgeries that can occur, and there are reasons that we can stop it temporarily. But when my patients ask if they're gonna have a dental cleaning, I tell them they can wait, because that's not that important right now for them. And also lifestyle modifications, heart-healthy diet, smoking cessation. So some treatments of ISR. Here is a little table. On the left, we have medical therapy. On the right, we have CABG, but in the cath lab, we focus on balloons, laser, rotoblator, stenting again, and IV brachytherapy. So class 1 level of evidence A, it's treat with another DES. And a lot of the trials that I did were in accordance to the RIBS trial. And RIBS 4 actually was showing the treatment of DES with another stent or with a drug-coated balloon. And here it shows that the DES shows that there's a larger minimal diameter lumen, larger net lumen gain, lower percentage diameter stenosis, and overall the cardiac death, the myocardial infarction, and the target vessel revascularization was significantly reduced in the EES arm. Also, a class 1 level evidence A is treat with a drug-coated balloon, but as Dr. Sharma mentioned, it's not approved in the US for coronary intervention at this time, but the SABRE trial was one of the first trials that they did. And depending on the patient's situation, what type of ISR we are talking about depends on if we go towards the balloon or the restenting with another stent. The balloons sometimes are preferred in smaller coronary vessels, bifurcations, restenotic lesions with multiple stent layers. Also, the stenting with another stent can be preferred in large vessels. And another treatment that I wanted to touch upon is intravascular brachytherapy, also known as IVBT. Our cath lab gets a lot of referrals for this just because they're not done in many of the institutions. And the way I explain it to my patients is that you can't put a stent in a stent in a stent. After 2 stents, we have to think of something else. So that's why we do the IVBT. And as we remember, there's re-narrowing after DES stent placement from the hyperplasia. So what the IVBT does is that the radiation inhibits the hyperplasia in the restenosed stent. This is the device that we use here at Mount Sinai. So basically we'll go in and then we call the radiation oncology team. And another question that they ask is how much radiation do we actually use? So it all depends on the vessel diameter. If the vessel is between 2.7 to 3.5 millimeters, we use 18.4 grays. 3.35 to 4 millimeters, we do 23 grays. And usually it takes about 3 to 5 minutes for the radiation dose delivery. And here is an article from Mount Sinai. Some names may look familiar. One of the fellows, or two of the fellows when I started, Dr. Batasia, Dr. Serbi, we have Usman Babar, Dr. Kinney, Dr. Sharma, and also the radiation oncologist that we work with, Dr. Buckstein and Dr. Bass. So what they looked at is in recurrent ISRs, they had one arm that had the IVBT, and then the other arm which was not treated with the IVBT, and what was that? They were treated with another balloon and stent. And this shows that there's less major adverse cardiovascular events with the IVBT. And last but not least, say you fail IVBT, now what? I found in TCT 2020 that there was another study done where they treated the failed IVBT with either a repeat IVBT or with stent and balloon. And this also shows that there are less major adverse cardiovascular events, both at 1 year, 2 years, and 3 years. So when Dr. Sharma told me about my topic, this is what I looked at, and I said, Dr. Sharma, how do you expect me to speak in 20 minutes on this? And my take-home message for everybody is there are great guidelines. It shows about the imaging that we'll be. I think someone else will be talking about later on today. There's different balloons, stents, brachytherapy, but just remember, it's very important to have a heart team discussion and also think about what's best for your patient. So thank you so much.